Welcome to Family First, Prioritizing Caregivers in Hospital at Home, a webinar sponsored by the Hospital at Home Users Group, presented in partnership with the American Academy of Home Care Medicine. Next slide, please. We'd like to recognize the generous support of the John A. Hartford Foundation for the Users Group and this webinar series. Next slide. Before we get started, just a few housekeeping details. First of all, please submit your questions via the Q&A option at the bottom of your screen. Due to the large audience for today's webinar, everyone has been placed on mute so we can have a good audio. If you have any technical issues, please contact Jane Donahue at jdonahue@aboutscp.com or send her a message via the Zoom chat feature. Folks often ask, the slides and webinars will be available afterwards on the Technical Assistance Center and on the events page of hahusersgroup.org. Next slide. Just a word about the Hospital Home Users Group, which is the nation's premier organization focused on developing hospital at home programs around the country, with more than 181 operating sites that are full members and 175 affiliate members who are in the process of developing programs. This dynamic collaborative shares resources and best practices, works together to expand the reach of our programs, and develops the program and policy standards to inform regulatory and reimbursement policies necessary to spread this hopeful model more broadly. Please visit our website, noted here, hahusersgroup.org, and be sure to check out our TA Center for helpful hospital at home program resources and tools, as well as our recently refreshed Research Center. Follow us on Twitter and X as well. Next slide, please. You can view any of the 23 Users Group webinars, some of which are listed there on our website. You can find a topic you've been thinking about or working on and take a look, or just if you have a few hours, many hours, you can, or a whole day, I guess, you can binge them all. Next slide. It's now my pleasure to introduce our moderator for today's webinar, Ronnie Snyder, who is Vice President for Program at the John A. Hartford Foundation. Ms. Snyder has more than 25 years of experience working with preeminent healthcare institutions across the nation, improving the care of older adults, identifying and guiding healthcare programs that have set the standard for medical best practices, increasing medical education opportunities, and maximizing resources to improve healthcare broadly. She brings that experience to the John A. Hartford Foundation, where she coordinates initiatives that foster collaboration among academic institutions, hospitals, and healthcare providers to build age-friendly health systems, improve serious illness and end-of-life care, and importantly for this webinar today, support family caregivers. And that is sort of part of the reason why she is leading today's webinar. Please take it away, Ms. Snyder.
Thank you so much, John. I really appreciate it. That was a lovely introduction. I will just reiterate, as Vice President for Program at the Foundation, where our mission is to improve the care of older adults. John just listed our three programmatic areas: building age-friendly health systems, supporting family caregivers, and improving serious illness and end-of-life care. And hospital at home really touches on all three of those. So I'm glad we're here today to talk about it. And I guess I would be remiss if I didn't mention the context of today's conversation, that our foundation played a long-term role in bringing hospital at home into the US. We started funding this work and partnering on this work in the 1990s. With some faculty from the Johns Hopkins Hospital, University and Hospital. And we have supported it off and on ever since as what we really think of as an exemplar of age-friendly care that is based on evidence and focused on what matters. Next slide, please. So after all these decades, it's been really gratifying to see the spread of hospital at home. Pandemic-related Medicare waivers allowed the model itself to rapidly expand, and it has been receiving a whole bunch of widespread attention. So just 2 weeks ago, it was focused on the NBC Nightly News, as you can see on this screenshot here. And here's the question we keep getting as part of this work. What is the role of and the impact on family caregivers, and how do we support them? So we see that both in the mainstream and in the trade press, as you can see again on this slide. And given our priority areas, it's a really important question to us. So fortunately, the early evidence that we have shows that there's not any greater burden on family caregivers in hospital and home. But nevertheless, it's really not an easy equation. And so therefore, in our most recent grant, we're explicitly funding research on the experience of and the needs of family caregivers so that ultimately we can better support them. Next slide, please. And so I also want to note that I co-authored a health affairs piece on this exact topic with Carol Levine, who is a well-known family caregiving expert and a caregiver herself. And we recommended, among other things, more research in addition to what we're funding at the John A. Harper Foundation, and also providing additional resources and tools. And the user group itself is already starting to do this. So thank you to everyone who's here. We firmly believe that the measures of quality we use should include a focus on caregivers. And so given all of this, I'm really pleased to be moderating today's discussion with a really fun and excellent group of experts, including a former caregiver and patient who we'll speak with in a moment, who I'm sure have some thoughts on these recommendations. Next slide, please. So let me introduce Jan Strasvogel. He is an opera director, impresario, and an author and a former caregiver in the Mount Sinai Hospital at Home program. His partner, Judith Norrell, is a former professional musician turned baker. I seriously want to come to your house. We're talking music and baked goods. I'm all in. In December of last year, Judith was afflicted with severe pneumonia and flu and received care through the Mount Sinai program. So during her hospital at home stay, Ian supported her as a caregiver. And I'm really, really looking forward to having a conversation with both of you in just a moment. Before we get there, let me note the other speakers that are coming up behind. Next slide, please. So we've got a terrific panel, and they include Brittany Howard, who is a PhD candidate in the Department of Anthropology at UMass Amherst. She is currently working on as a research assistant on the Hospital at Home and Caregiving project that's being conducted through the Icahn School of Medicine at Mount Sinai. So really grateful for your research there. Next, Rita Chula is a friend of mine and Senior Director of Caregiving with the AARP Public Policy Institute. She manages and also provides context and content expertise on internal and external family caregiving initiatives with a specific focus on identifying and supporting the needs of multicultural family caregivers. So you know, Rita, we really need your perspective. And then last but not least, Dr. Pamela Sanger is a home hospitalist at Yale New Haven Health. So previously, she's worked as a physician implementation lead at Medically Home, which does a lot of hospital at home. And before that, was a part of the team working to expand the Mount Sinai at Home program in New York City. So lots of convergent experience, and we look forward to hearing from each of them. So with that, let me turn to Jan and Judith. Thank you both so much for being here with us. I'm going to start with a question for Judith about your experience. If you will, please tell us a little bit about how you were introduced to hospital at home and you know, sort of your experience. Did you have any misgivings, and why did you choose hospital at home?
Absolutely not. I felt it really saved my life. I did not know anything about it. It is not known, at least in my area, the Upper West Side of Manhattan. And being able to get out of the hospital and being taken care of at home, beautifully taken care of, not only by Jan, but also by our two daughters who came in. One came in from Europe, but basically Jan taking care of me. And the nurses, the fantastic nurses, as well as the doctors with whom I communicated every morning, made all the difference between my getting better and not getting better. But I didn't think about it until one of the doctors at the hospital said, when I said, I can't stand this anymore, being in the hospital, he said, well, maybe you'll be eligible for hospital at home. Is that correct, Ellen?
I think so. You
yes. And I was accepted.
So you didn't have any misgivings to begin with?
Oh, not at all.
Oh, no. course not.
to be home as opposed to a hospital atmosphere where you get awakened at 3 o'clock in the morning to have your blood pressure taken and a blood sample given, or to drink some horrible thing instead of sleeping. The noises and the nurses who have so many patients to take care of, the food that is inedible by the time it gets to you, the not knowing who you're going to talk to, if a doctor will come by, no one tells you anything, of course, because everyone is so busy. And there are people who really don't want to be in the hospital. And certainly on my floor, there were people screaming, shouting they wanted to go home. It was night and day, or hell and heaven.
Got it.
I think.
Wow, oh, go ahead.
I have to say, slightly contradicting Judith, that the hospital, of course, had the services at the beginning that saved her.
Yes,
And we can't totally forget that. I
that's
certainly
true.
can't.
That's true.
It was essential that I take her to a hospital.
To
But it
start
was
there.
absolutely equally essential that she leave as soon as possible. The doctors felt she was well enough and there was a space in the program. And so she was released to this program, which amazed us. We had no idea such a thing existed.
Right.
And it was wonderful.
You both have already added a lot of color to this conversation. Jan, can you tell us a little bit about your caregiving experience in hospital at home? Sort of, how long did it last? How often did you communicate with a nurse or a doctor or some other professional? And what that sort of felt like for you?
Okay, well, if we're talking about the actual period, it was 1 week that Judith was in the hospital at home system. She was dismissed on the 1st of January, an excellent New Year's present, and she was had been admitted December 26th, so it was 1 full week. And during that time that she was under the care, nurses came, I think, in the morning and in the evening. And in the morning nurse was also then supervised by a doctor on video, who would see how Judith was progressing. To my amazement, as part of this home care, on one day, because they were concerned still that she might have pneumonia infection in her lungs, a guy literally came into our apartment with an X-ray machine. I thought, this is truly the future. I had no idea, and I'm relatively informed that there were such things, and took a picture of her. They had first wanted her to go to the hospital. That was out of the question. It was, no one was going to go to the hospital with Judith, still really in the middle stage of recovery from a horrible infection. But the guy came and he took the picture, and evidently it showed that the lungs were clear. And I thought, this is just amazing.
That's fantastic. Jan, I'm going to stay with you for the next couple of questions, but Judith, please feel free to sort of jump in if there's something critical you want to add, just a little bit of flavor. Jan, what were the most positive and conversely challenging aspects of being a caregiver during that time at home?
Well, what is challenging is that we've both been very fortunate with our health. So the unfortunately rather common experience of severe illness that befalls most human beings had really been spared us. So this was first for both of us, and it was shocking. It was, as we say in America here, a wake-up call. It caused a great deal of intense, swift decision-making and hard thinking. I had no experience in caregiving because I've been spared it, so I can't compare. There's no before and after as far as I'm concerned. But certainly to be a concerned partner, to see your loved one in a hospital is a very different kind of relationship that you have. You can do only so much. You can advocate. It wasn't, I don't think, very much necessary, but was occasionally necessary at the hospital. But basically, the hospital is this machine that functions day and night without any input from you or me, or at least from me or Judith. And at home, it's of course different. First of all, the food is infinitely better. And second of all,
We're
and
big
which is
foodies.
really important, much more important than hospitals think, it seems to me. It's really important. And we are foodies, of course. And also, I could really, I could see the daily improvement or have the daily concerns such as they were and immediately contact someone if I needed to. But honestly, every day that she was at home was accompanied with improvement. I mean, the real sort of guide to us in this period of her particular illness was how much she needed the oxygen. And once she was off the oxygen, it was time when the doctors finally felt that she could be released from the home hospital at home program.
I
So
would
let
like,
me, oh, go ahead.
Please.
not only Jan took care of me beautifully, but the nurses who came were so wonderful. The nurses had chosen to be in hospital at home as opposed to many of them had been working in the hospital. And their attitude towards us was so humane. They shared their personal stories with us. They were relaxed, whereas in a hospital, nurses are running around dealing with I don't know how many patients. It's a totally different experience.
Yeah, and it
That's
is,
a really important fact.
yeah, I think also the kind of nurses who want to do this
Yes.
program are, I think, more independent in their spirit.
Yes.
And I think maybe more directly compassionate that it's, I respect all nurses, I really do, but it isn't just a job at all for them. It's something very special. And there was one nurse in particular, I remember, who came in when Judith was still really very low and said, "You're going to get well, you'll be fine." And it was really irritated Judith, to my great amusement. But in the end, I think you
Well,
recognize
she then said, "I'm your birth twin. We happen to be born on the same day, not the same year, but the same day." And she really pushed me. I told her, "Go away, go to hell," because she was so positive. But she really did make a difference.
Right, and this would not happen in a hospital,
Not at
or
all.
very unlikely to happen.
I'm gonna end with one last question and then sadly we have to move on because I would love to hear so much more from you. What kinds of supports did the hospital at home program offer you as a caregiver? Were there specific caregiver assessments or trainings or other supports?
No, there weren't that I'm aware of, no, I mean, again, I think that they don't, at Mount Sinai at least, they don't allow people into the program unless they figure that the medical supervision, the medical treatment is something that can, that someone at home can handle. But no, there was not, it wasn't necessary. It seemed to me it was very helpful though, that the doctor, there was a doctor each day, and again, extremely compassionate group of doctors with 2 or 3 different ones, I think,
Yes.
really excellent, who were, I think, in all cases on the younger side, who supervised and made observations about how Judith was going and heading, and how much longer would be necessary to be in care.
One thing they did do, which was helpful to both of us, was that they put out the pills.
So that is helpful.
Helpful
Really
on
helpful.
which one's in the morning, which one's at night,
Absolutely. Yeah.
Great. Well, I am reluctant to move on, but we have to thank you both so much for sharing your experiences. I won't be surprised if there may be questions for you later on. And now I'm going to hand it to Brittany Howard to speak with us next.
Hi, yes, thank you. And I really loved that interview. That is the essence of what I'll be discussing now. So yes, my name is Brittany Howard, and I'm going to discuss the hospital at home caregiver experience study that I'm a part of. Next slide. I'm going to briefly provide our study overview and then focus attention on the caregiver component of the study, including key takes from the literature, our study design, and an ask for help with our caregiver recruitment for the study. Next slide. Thank you. I'm part of a team of researchers at Mount Sinai, New York, for the moving hospital at home into mainstream of healthcare. For this study, we aim to identify the range of diversity, equity, and inclusion challenges relevant to the unique features of hospital at home care delivery, research, and policy. We also want to better understand the scope of caregiver-related issues with hospital at home, including various challenges, expectations, and needs from the program. So there's two components. For the equity component of the study, this past fall and winter, we recruited leadership from the Hospital at Home users group and interviewed 18 hospital at home program sites, which included 27 individuals. So sometimes there's more than one person on a Zoom interview. This sample included a national cross-section of hospital at home programs. We focused our attention on issues related to equity in hospital at home screening, enrollment, care processes, and outcomes. These interviews also touched some on caregiving involvement, the technical assistance and related tools provided to caregivers, and how to improve support for caregivers. For the caregiver component of the study, our aim is to interview 15 to 20 caregivers, and our focus is on the experiences of caregivers, including expectations of what the care would be, how well it fit with expectations, the education about hospital at home, and issues related to any family caregiver strain, burden, and burnout. Next slide, please. So I'm currently screening the literature specific to the model used by Hospital at Home user group. There is application of hospital at home programs worldwide: Canada, France, Norway, the UK, Singapore, and others, spanning a length of time since hospital at home was developed in 1995 or so. A large portion of the publications mention or discuss caregivers as an important part of the program model and provide effective models of care that engage these family caregivers. But little is known about the scope and experiences of the caregivers themselves, especially related to diversity, equity, and inclusion. Several studies indicate that caregivers perceive hospital at home as safe and effective, and found that caregivers in their respective studies experienced lower rates of stress and stressful situations than when family members are in the hospital setting. Some report also that caregivers have more comfort being at home, and food oftentimes comes up in some of these findings as well. However, hospital at home can and sometimes does cause stress, disruptions, and burdens. These are discussed in the literature, and the results vary, likely due to the heterogeneity of programs with diverse patient groups. Caregiver stress, emotional toll, and caregiver burden can be high for those working regular jobs alongside their caregiving roles. And caregiving can fall disproportionately on women and racial ethnic minority groups. Burden can include disrupted space because of medical supplies in the living areas, the laundry, the kitchen, things that you might find there's staff for at the hospital, emotional factors and stress, and disruption to time and other family obligations. Various authors present possible solutions to caregiver burden, including mental, technical, and clinical supports, training, resources, and even frequently asked question materials. Many in the literature recognize the need for well-defined caregiver roles and training, and having better resources and metrics for how to best educate and train caregivers for hospital at home. Finally, involvement of caregivers in the overall care team is discussed by many authors, which includes having responsive hospital-based health and service communication with the caregivers, also to decision-making and care planning with the caregiver and clinicians as a team. So we're seeking to contribute to this limited published literature, specifically from an equity standpoint. Next slide. So for the hospital at home caregiver component of the study that I'm involved in, we started recruitment in October. We've interviewed one caregiver to date with the aim of doing 15 to 20 caregiver interviews across the country. We're doing 45 to 60-minute semi-structured Zoom interviews with the caregivers. The interviews are designed to address the gaps that I just mentioned in the literature. So this includes what resources and training caregivers receive prior to and during the hospital at home stay, hearing from them about their onboarding or initiation, and experiences as a caregiver during the duration of the stay. And also ways to strengthen hospital at home programs for caregivers. So our current recruitment strategy has included a number of approaches. So we've asked hospital at home frontline program staff and leaders to share our recruitment flyer with caregivers. When staff or caregivers have the link from that flyer, they can complete a red cap form or email myself or other Mount Sinai team members on the study for us to connect. We have also posted our flyer on recruitment calls, so the Hospital at Home User Group Basecamp page, the AARP Community Board for Caregivers, and some other resource boards online. And as I mentioned, this hasn't yielded results so far. So one challenge that we have found in hearing back from different frontline staff and program leaders is that different programs and hospitals are concerned about IRB and ethics approval at their respective institutions. And this has caused a bit of a pause or hesitation from folks sharing our research flyer with caregivers in their programs. Next slide. So for folks who may be concerned about IRB and other ethics boards, one of our partners has used this approach that you see on the screen. So the Mount Sinai IRB, first of all, considers that sites taking part sharing our flyer are not involved in the research study itself. Okay, so that's step one. And we can provide the materials to get a determination statement. So one of our referring institutions, someone who's referred caregivers to us, submitted various materials from us to their IRB, and they reviewed it and determined that they did not have engagement in this research. So folks can take these steps to also get a determination from their IRB. Next slide. And finally, last slide, we would appreciate any help you can offer for recruiting caregivers to take part in our short, 45-minute to 60-minute interview. So you on the call, caregivers, or other interested parties can email me here at brittany.howard@mssm.edu or use this link or this QR code to sign up. So thank you. And the very final slide that I know will be shared are just some resources and some key takes that I took from the literature. Okay. All right. And I believe I'm passing it on to the next speaker, Vida.
Thank you so much, Brittany, and good afternoon to everyone. Looking forward to this conversation and really want to thank Judith and Jan for sharing their story. It's always so important to hear from individuals that are living what we're talking about. I'm going to spend just a little bit of time today talking about some work that AARP has been engaged in for a couple of years now. In 2022, AARP, along with ATI Consulting, we put out a publication that really took a closer look at how family caregivers were or were not engaged in hospital at home programs. We interviewed several programs and leaders of those programs to get a better understanding of that. And within that publication, which I will post after I speak, we laid out some considerations for programs that are looking to engage and better support family caregivers. I want to, there was an NPR article that Ronnie had on one of her earlier slides, and in that was Dr. Donna Benton, a colleague from USC, who was quoted, and she said, "As family members, we will always say yes, but we don't know what that means." And so as I talk a little bit about and go through these slides, I think it's important to remember that that family member is likely going to say yes, but what does that yes mean? Next slide. So for the first group, we broke it down into 4 categories. The first is ensured choice, access, and equity. And I won't go through all of the bullets on all of the slides, but really wanted to take some time to highlight a couple of bullets from each. And the first on this slide really is about voluntary participation. We heard the conversation that is had with the patient about this opportunity, and often the family member. But what does that look like for the family member? And does that family member have any opportunity, once they understand what this will look like in practice, to consent to that along with the patient? You know, is that conversation being had with the family member in the room, or is this a conversation that's being had with the patient, who is very excited about being able to receive the support in their own home setting, not necessarily maybe always understanding the impact or the requirements on the family caregiver? Another piece is around equity, really important to eliminate barriers in order to serve patients across all demographics. As we look at various hospital at home programs, are they inclusive of race and ethnicity? Are they diverse, socioeconomic status, and age? You know, we look at various age groups and what comes with being in those age groups. Are these individuals working? Do they have younger children in the household? A variety of things to consider. Next slide, please. The next piece is really about being clear and understandable to patient and family caregivers. So, are there clear expectations of all the services, how to access them, and really importantly, the caregiver expectations? What is this caregiver going to be expected? What help are they being expected to provide within the home setting, both as they transition to the home from the emergency room, once they're at home, and then as they transition out of that care? Is this a conversation, as I said earlier, that is actually being had with the family caregiver? And is there an opportunity for that family member or friend who has been identified as the caregiver to really be able to ask questions? And not only ask questions, but are you, as the healthcare provider, anticipating questions that they may not have because they don't know the full extent of that care? So again, as you are engaging that family caregiver, really being open and honest with what that care looks like. Next slide. When we're thinking about admitting someone and offering this as a option, should we say should it should not increase net caregiver strain relative to inpatient stay. So again, think about what is that caregiver may or may not be responsible for if they are at bedside in the hospital, versus what they're going to be asked to do at home. Quite often we hear from programs that caregivers say, we don't have to pay for parking, we don't have to go back and forth to the hospital. And all of these are valid, positive reasons for an individual to want to care for someone in the home. But we want to make sure, again, that it's all things. We're not just looking at a couple of things, because as we weigh these various options, it may look different depending on that family caregiver. And this really goes to another important point, is really understanding that for every caregiver you see, you've seen one caregiver. And so having those individual conversations with families is really critical, because it is different depending on the household. Also, those services and supports, are they available to both the patient and the family caregiver? If we think about meals, we did hear from some programs that they do offer meals to the family caregiver as well as the patient. Are there other opportunities for that caregiver to get support as they bring that care into the home? And finally, training family caregivers on medical tasks if interested and desired. We know that caregivers and the patient have nursing staff that come into the home 1 or 2 times a day. We know that there's always an access point for someone to be contacted remotely. But are there things that caregivers are being asked to do that need a little bit more training? And are those caregivers actually receiving that training and know where to go if they have a question? Next slide. I'll close on consideration for research and learning. And thanks to Brittany and the great work that the team is doing in really increasing our understanding of research around hospital at home programs. There's an opportunity for that research to continue to expand, especially as it applies to family caregivers. It's very critical that we have these studies that really not only do the research on the patient, but really the impact on that family caregiver, those family and friends that are providing that care. Are there additional stresses and strains? As Brittany talked about, many of these family caregivers work. There may be younger children in the household. What are those things that those individuals are being asked to do? And what are those impacts that are being had on those caregivers? And it's not to say that because there's an increased stress or strain that a family caregiver is going to immediately say no. But as a program, as we ask hospitals and health systems to do inpatient, it's really critical that if we are relying on family caregivers to provide this additional level of support, that there are resources for them. And so better understanding the impact on these caregivers allows proper resources and tools to be developed to really support them. And really mechanisms, to improve the program based on assessments. It's really important, again, that we take that research and that we apply it across programs. So don't recreate the wheel. If one program is doing something, can we make this somewhat standard across hospital at home programs? Are you learning from each other within this hospital at home users group and beyond? And so in closing, I'd just like to say that hospital at home programs do often offer choice for both patients and families, especially as more care comes into the home. But it's really critical that we work to ensure that family caregivers are really an active, recognized member of the care team and are given a voice in the care that they are being asked to provide. Thank you.
Thank you, Rita. That was great. And now I'm going to pass it on to Pamela Sanger.
Thank you so much,
Ronnie.
Ronnie. Yes, and thank you, Rita. Such important points. I'm also honored to be a part of this discussion, and like all of you, so grateful to Jan and Judith for sharing their experience. So I'm going to be talking about hospital at home supporting caregivers in practice. First, I wanted to make 2 points about the hospital at home model of care and caregivers. The first is that not every family is going to want to implement hospital at home care in their home in the same way. A caregiver in one family may need or prefer respite, and the hospital team must provide all direct caregiving in the home for the duration of the episode for it to work. While there could be another caregiver in another family who might actually prefer to continue providing some or even all of the direct caregiving during the hospital home episode, and therefore wants more limited supports. Either way, it needs to be the choice of the caregiver and the patient. And that's why it's so important to purposefully elicit these preferences in the initial conversation about hospital at home care. And the second observation I wanted to highlight is that hospital at home is not a static model. So the basic structure is consistent across most programs, especially among the CMS waiver programs. But every program is a little different. And as we heard at the beginning, new programs continue to open up at a steady pace. And both existing and new programs are continuing to improve and innovate in many areas, but including that of caregiver involvement and support. And there is great work ongoing within the users group around codifying a set of hospital at home program standards. So this is all sort of evolving as we go. So I think we've all agreed that there are clearly many things that HA programs need to be doing when it comes to caregivers. Among them, finding out who they are, what their relationship is with the patient, the levels of involvement, including them in that decision-making and the consent process when hospital home care is initially offered, providing them with information about their role and involvement. And then once the patient is admitted, keeping them apprised of the patient's progress and plan for discharge. So focusing just on those last two items, I wanted to show a couple of examples of how HA programs today are involving and supporting caregivers. So we can go to the next slide. So first, I'm going to showcase two examples of hospital at home program written materials for caregivers. On the left is a template example that's available on the users group's website in the Technical Assistance Center that can be sampled, remixed, excerpted, used as an inspiration. And on the right is a caregiver brochure that's in use out in the wild. Many thanks to the Texas Healthcare at Home team at Texas Health for generously sharing their flyer with us for this presentation. So why provide a brochure targeted specifically at the caregiver? It complements the patient brochure, which may not address caregivers, and it explicitly acknowledges their important role in the care and can provide answers to their common questions and concerns. You can go to the next slide. So both resources aim to clarify the caregiver role and what's expected of them. In the users group template, we clarify that the caregiver is considered part of the care team with their unique knowledge of the patient and their needs. Whether or not they plan to participate in direct caregiving during the episode, they should be acknowledged as a care team member. It also specifies that how much they want to participate in that direct caregiving is up to them and the patient. It goes on with the list of do's and don'ts, which aims to answer some common questions from caregivers. And on the right, the Texas Health Caregiver brochure includes a list of ways the caregiver can assist during the episode. It's not a checklist or an assignment, but rather suggestions of activities that can support the patient. Next slide. Both tools prompt the caregiver to communicate with the care team. So the example on the users group website includes a communication planner with space for the caregiver to write notes, take down questions they want to ask, and reminds them to share when and how they prefer to be contacted. And the Texas Health Flyer explicitly encourages the caregiver to ask questions and lists several ways that they can get in touch directly with the care team. So both of these flyers are setting up the caregiver to be involved and connected. Next slide. And finally, it must be the aim of each HA program to avoid caregiver stress and burnout as much as possible. As we heard earlier, the research does seem to support the notion that hospital at home care for a loved one does not, in fact, lead to higher levels of caregiver stress compared to inpatient care. But a caregiver informational resource is a good place to remind caregivers to check in with themselves and practice self-care and prompt them to communicate if they are becoming stressed. And if that happens, each program should have a plan of action to both ensure continuity of care for the patient, as well as a way to connect the caregiver to social workers or those who can offer resources and connections to community supports. Next slide, please. So I'm going to shift gears and move on to a different example of how HA programs are ensuring that caregivers are involved in the patient's care and apprised on the patient's clinical plan and progress. Many programs are using tablets in the home with the patient's daily plan and clinical information available and visible. At the users group annual meeting in October, Mandy McGowan, Director of Home-Based Care Programs at University of Wisconsin Health, presented on how they're using Epic MyChart Bedside to share in real time the patient's care plan. I want to thank her for sharing her slides with us. And as you can see here, the patient and the caregiver can both see the diagnoses, the ordered medications, and the planned visits. They can read about the care team members, make or receive video visits, and read and send messages. Next slide, please. And I really want to emphasize one major benefit of the tablet interface. The caregiver can actually plan their day around the patient's scheduled visits, the nurse, provider, or therapy visits, and choose when and how to be involved. By seeing the visits and their times in advance, the caregiver could even ask the care team to adjust a visit so that they can be present. For example, moving a wound care or a therapy visit so it fits best with their schedule. This is a major difference from typical hospital-based care when, as a visiting family member or a caregiver, you're never sure exactly when the attending or specialist or therapist will round, or if they'll have time to come back later if you miss them. Next slide, please. So these are just two examples of how HA programs are engaging, involving, and supporting caregivers of HA patients. There is, of course, much more work to be done, and I think we all look forward to seeing how how leaders and practitioners continue to build on this. That's all for my slides. Back to you, Ronnie. Thanks so much.
Thank you so much, Pamela. Wow. Just a big thank you to Jan and Judith, to Brittany, Rita, and Pamela. That was really fantastic. And so now we do have a little bit of time for some questions from the audience. And I actually thought the first question was great. I'm gonna sort of start at the top and see how many we can get to. And I'll say one other thing, which is, even if we don't get to all the questions, the team is capturing all of them to inform the work moving forward. So if you've got questions, don't hesitate to put them in the Q&A. So the very first question that we have here says, if your caregiver had a magic wand, what other improvements would he want to see? So I think that one's for you, Jan, or both of you, Jan and Judith.
I had a very silly thought immediately. We never knew when the only time we knew when the nurses were coming was they would call us and say, I'll be there in 10 minutes. So if Jan wanted to go out for a walk or do shopping, or someone wanted to go out, especially in the afternoon, because the nurses would come depending on when they finished their last appointment. It could be any time between 2 p.m. and 8 p.m. It would have been helpful to have a general idea. That's
A bit of a tighter range.
if possible, but certainly we were so grateful it didn't really matter. And I also want to add that I do realize that our situation is so much more fortunate than many people. We, relatively speaking, I was sick for a very short time. It was not caregiver burnout, I think.
No, she was getting better.
I was getting better. So it was a very positive atmosphere after a few days of waffling at home. I think the nurses were happy to come. They also said, one of the nurses said that our family was so united and so loving together, and it was a wonderful experience for them to see that, because some families that they visit are really struggling. Children arguing, who knows what's going on.
Yeah, about in the pressure of severe illness, children have vehemently different notions about what's right for mama or papa, and it was clearly very disturbing to the family and certainly to the nurses to witness this. I mean, that you are in the home, you are in much more inside the lives of the patients than you are in a hospital. But the fact is that the patient is benefiting in general, it seems to me, from being at home.
You're fortunate in an additional way that we haven't touched on as much, which is to say that you, Jan, were the primary caregiver, but you've said that your daughters also helped. So it was not, whatever strain there could have been was not yours alone.
No, correct. No, it was very fortunate that our daughter from Germany, who lives in Germany, was able to come over during her winter vacation to help us. It was tremendously helpful. And our second daughter also was occasionally able to come in from Connecticut. So that was
great.
Yes, we were very lucky.
Yeah. If you could imagine, because you just sort of dipped a toe into the waters of, if you had a longer term or a more serious illness, if you were facing that, would additional or different prep have been helpful as part of this hospital at home journey and going home to take care of someone?
Well, certainly. I mean, again, everything is based on this. Really, that question is really based on specifics. I had the impression, I don't know what the protocol is at Mount Sinai for triggering patients to be released to the hospitalization at home program, but certainly a more complex series of pills, a more complex kind of program for Judith maybe would have been much harder. Or for me, I found it very easy and very reassuring but she was here. And our daughter was here, and we could take care of her. But the impression I had was that Mount Sinai is careful not to let patients into home care where the home itself is really going to be taxed either by machinery or complex schedules of medication or elaborate procedures that have to be done every day to help the patient recover. There seemed to me to be a discrete area where it was possible to be done, and then after that, Mount Sinai wouldn't allow patients to leave the hospital.
Well, that's important.
Thank
you both.
You're asking me to make a comment about, I just was so basically happy and we were so helped by this that it's just, I just had no idea that such a thing was even possible, and that it was really, in our specific case, an immense help and a great relief.
Fantastic. Thank you so much.
You were working 9-to-5 jobs, or if Jan were working 9-to-5, it wouldn't have been possible. And if our children,
Well, I would have made it possible for
Right,
sure.
right.
Of course I would have.
But that's an important perspective.
It is, yeah. It is a real concern. We had young children at home, of course. It's a much more complicating thing. We were, in that sense, also very fortunate.
Right. All right. I'm going to turn from the caregiver himself or yourselves in this situation over a little bit more to the clinicians. And so, Pamela, this is probably more for you than anyone else, but anyone can jump in. So one of the questions asked, what training is provided to hospital at home healthcare providers? And the examples they used weren't just physicians, but nurses, social workers, others in the program, to equip them to assess and support caregivers on a routine basis.
That's a great question. I think I lost count, but we have 200 or 300 hospital at home programs across the country, and I think you might get 100 or 200 different answers to this. The bottom line is there's a lot of variability. There's a lot of variability in terms of what the staff that makes up the team, how deep the bench of social work and care management is available to the hospital at home team, as well as what training all of the providers and clinicians are getting when it comes to working with caregivers. So I can't give an answer for the HA model itself, but one of the things that, again, the users group is working on is surveying as many of the programs as we can locate across the country and finding out what people are doing. And then we want to pull those best practices. And that's work that this program standards work group is currently undertaking.
Great. Thank you. We've got another question that I think is also probably most appropriate for you, Pamela, which is about remote monitoring devices and whether they are sufficient to really fully manage at-home care and how they're integrated into this particular model in your experience.
Yeah, so again, different programs are doing things differently. Some have kind of more continuous monitoring that's being fed back to them. Others are more kind of moment in time capturing of vitals. But I think every program, part of the admitting process is making sure that it's the appropriate amount of monitoring for that patient. So if a patient needs more intensive monitoring that isn't available, that patient would not be offered the program. So it's a not your ICU level patient who might be needing to be reintubated, but a more stable patient who would be appropriate for this program, and whatever the technology that particular program has in the home. So that's a huge piece is that kind of patient evaluation and screening before the patient goes to the program.
Absolutely. Thank you, Pamela. I'm going to switch over to Rita. So our first question was about magic wands. And Rita, if you had one of those, I just want to know, is there one thing that you would suggest from the perspective of, the work you've seen and done at AARP, and specifically with a diversity lens, one thing you would suggest to improve hospital at home practice with regard to caregivers, what do you think it would be?
I think it really revolves around that conversation, right? And ensuring that we're not looking at one type of family caregiver, really recognizing that family caregivers come from all different backgrounds. They're living in different communities and they have different cultural traditions that can impact how the individual receives care and how that caregiver provides it and who is in the home to help provide that care. And so it's really important, again, that as we develop these great tools, both on the provider side and for family caregivers, that we take that into account, much like we're trying to do in the hospital, the physical hospital itself. So again, just really recognizing the diversity of that care and meeting that patient and that caregiver where they are.
Thank you. That's fantastic. So the last item I'm going to add with regard to this panel, it's not really a question, it's kind of a plug. Brittany put in a request, her call to action for the clinical folks and teams on this line around finding ways to identify and recruit caregivers to talk to the hospital at home group at Mount Sinai so that we can really learn more, so that we can better assess what is needed, what's helpful, what's not helpful, and how the experience plays out. So on that note, I just want to say it's really important to all of us, to everyone I think on this Zoom, to consider the needs of family caregivers in hospital at home and in all of our programs. We know that family caregivers are the critical workforce that makes so much of the rest of our healthcare system work. And we do see at the Johnny Harper Foundation that meeting the needs of family caregivers is an essential component of what we consider to be age-friendly care. And with that, I'm going to turn it back to John Bielenson.
Thank you, Ronnie. We can go to the next slide just to close up, to remind folks about the other webinars that in our webinar series. Again, you can find these on the events page at hahusersgroup.org, and we encourage you to take a look at any and all of them. The next slide. Again, just to remind folks, the information about the Hospital Home Users Group is at hahusersgroup.org, and the Technical Assistance Center that was described earlier. There is a special section on resources for family caregivers, and you can see the link there. It's kind of a long link, and it may be difficult to get that, but you'll see that in the slides when we do send those out following today's webinar. Next slide. And finally, a thank you to the American Academy of Home Care Medicine and, of course, the John A. Hartford Foundation for its stalwart support over these many years, these 3 decades, in terms of its support of the hospital at home movement, and particularly the Hospital Home Users Group. Thanks to Ronnie Snyder, our able moderator today, for organizing, facilitating such a robust and interesting conversation. Thank you to our panelists, to Ian and Judith for providing their stories, to Brittany Howard, to Rita Chula, and Pamela Sanger for again providing your perspectives on this important issue. We thank all of you in attendance today for your time and attention, and we look forward to seeing you on our next webinar in March, and we'll be providing information for that through the Hospital Home Users Group shortly. Thank you very much.